and an avid surfer.
He surfs every day too.
Looking at some of the biggest health problems that we have, diabetes is my second, I don't know if it's love or hate, but other area that I focus on. Trying to get diabetics to actually eat appropriately so they can get their blood sugar under control is very, very difficult. And the more complicated it is, counting this, counting points, adding this part on there, trying to figure out whether this is one bread or three sugars in their food. Most of my patients, and I've got some pretty educated patients, they tend to sort of throw the books up in the air and just say, I'm going to eat what I'm going to eat and give me enough medicine that it keeps my blood sugar where it belongs. One of the joys of using the meal replacements, besides helping people to normalize their nutritional intake, is it has made it so that I have, if they're following the program that I'm recommending on there, very, very few of them, including some that are insulin dependent, are still requiring that they use their medications. And Johns Hopkins has worked with a lot of meal replacement programs and done a lot of research on it, and it has, if I can get it to work in there, provided over 30 years, over 20 years worth of information back. This is one of them where they just looked at meal replacements versus, let me go back and look at that, the ADA diet, which we're all familiar with. I don't know whether that was 18 or 2,200 calories on average, but it fit the people that were in it as far as the weight that they were there. And then when they looked at it, you know, if they were doing meal replacements, providing their nourishment versus the other, how well did they do? And they found that it's much harder for people, as it is with just regular folks living in the crazy world we live in, to get in the nourishment they need in the appropriate amount. And that's one of the things that the meal replacement programs provide. When they flip them around, they look first at 6 months with using the meal replacements and then put them on maintenance versus the ADA, and then they compared them in there. And what they found is that when they switched back, that if they went onto the meal replacements, they continued with their losses and their weight loss and control in there. And let's go on there. This guy's up here. There we go. So they were able to decrease their medications. They showed a definite improvement as far as cholesterol. Blood pressures improved because that went along with weight loss, and they just generally felt better. And that's just the difference in nourishment, appropriate nourishment. There's no magic in any of the meal replacements that I use. It's food. But what makes it different is it's just like fast food, but it's good for you. You know, the reasons that McDonald's and In-N-Out Burger and all these places exist is our lifestyle is really fast. Nobody's got time to cook. Nobody wants to go shopping. And nobody wants to clean up afterwards, and it's inexpensive. It's cheap. Depending on which products you're using meal replacements, you can have all that convenience, but you actually can have good food in there, and that makes a big difference in there. As long as your proteins and your carbohydrates are balanced that are in it, that you know what it is. It's not go get a bar. You know, I've got a bar in my purse that I'm very comfortable handing to anybody that I'm going to be providing good nutrition to them. If you go down to get a Clif Bar, you've got more fructose, high fructose corn syrup than you want to put in your body in there. So having a control of what's in the meal replacements obviously is important as well. Let's see if we can move this along. Typical morning. Obviously this guy's not having a very good day. Insulin is our gatekeeper molecule. It's the thing that stuffs all of that blood sugar into places we don't want, into our fat rolls, into our livers. My ex-husband thought he needed a back surgery. What he had was fat in his spinal cord. It wasn't a herniated disc, so he lost some weight and skipped the surgery. Following the kind of ingestion, now this is a really bad person, but they could also be eating rice for lunch. They could be having a bagel in the afternoon instead of a candy bar or something like that. All it takes is something that has high glycemic carbohydrates in it. Your blood sugar goes screaming up. Your pancreas says that's too much blood sugar, Mr. Brain doesn't need that much, and dumps in insulin. And it always, when insulin comes in, it always overshoots the mark if it's following a peak like this, and you end up dropping your blood sugar down below the basal level. That's the level that your brain's happy at. That's where it's got easy access into carbohydrate, and brains can only eat blood sugar, as we all know. There's not very much else that it takes as far as nourishment. So as soon as it hits that dip down there, what it does is it says, go eat again. And that's why these people, we used to just think it was Chinese food that did this. It actually is why at an hour and a half, people are starting to get sleepy, and after that, they get hungry again. And they go on and on and on. If you are using low glycemic meals, then your blood sugar doesn't go up as high, it doesn't come down as low, and you don't end up with the fluctuations in blood sugar that are there. Let's move this along. Insulin in normal levels is a good guy. In high levels, it's one of the most inflammatory molecules there are out there. Controlling insulin levels knocks down the amount of inflammation that's present in it to a significant amount. And when people are making their choices of food, it is, how would we best explain that? A carbohydrate is not the same depending on its effect on blood sugar. And most folks think that anything that is green is good for them, and anything that is a vegetable is good for them. There's lots of different foods that may or may not be good, depending on what their glycemic index is, which is just purely the effect that the particular nutrient has on blood sugar. High glycemic foods are ones that crank the blood sugar up, like that big spike we showed, and low glycemic ones are ones that bring it up more gradually and more slowly, and that allows our metabolisms to hang on to it, not put it into storage, and actually utilize it. Just having people familiar with the concept of glycemic index can make it so that they can make some wiser choices. When I ask people what the healthiest breakfast is, almost invariably what I get is oatmeal. The glycemic index of table sugar was arbitrarily assigned 100. If you're doing Quaker Oats, the instant oatmeal, its glycemic index is 82. If I ask them what's better for you, a potato or some rice, just about all of them will say rice. Well, if it happens to be white rice, its glycemic index is 92. You're sitting down to a bowl of sugar for an awful lot of these things. So just having the information as far as what are you doing to your body when you're making choices is a huge eye-opener for my patients. I got a bunch of these charts, and it's actually out of Dr. Anderson's book, but that are there so that they get used to the idea that choices, even if it's a fruit, can make a difference. He's got a huge number of them in here that are there, and the books are here if you want to take a peek at them. And things that they thought were good for them often aren't. If you choose a blueberry over a blackberry, its glycemic index is about 20 more than that. So it's a pretty simple choice that they can make through the day with a little bit of education. So learning the habits of health requires both being willing to go forward with making some choices that are good for your health, but it's also figuring out what you're going to do with it. Besides having them lose weight in whichever way they choose to, hopefully with using multiple small meals. Adding a health coach, they've done studies that show whether or not it's a person talking to them, whether it was a computer talking to them, or if it was just mail that was coming out. The mail things did absolutely nothing. Having the computer nag them added about 2%. Having an interaction, even if it was just on telephone, we use in our office, they can come in and see me if they're diabetic and I'm bringing them down on this. If it's just a regular person with some general health habits, I have them meet with health coaches that just spend, sometimes 5 minutes, sometimes 3 minutes on a regular basis, once a month, once a week, depending on where they are on the program in there. It makes a huge difference as far as whether or not they continue to stay on their program in there. And I'm going to flip through this stuff and go back to. It's basically what we've been talking about. We can choose, the habits of health, and that's making wiser choices and maintaining them, or the habits of disease. This kind of shows a way of thinking about it. Is that today, if you guys had had a salad and a cheeseburger for dinner instead of what you did. It's not gonna change anything tomorrow for you. If, hold on here, if you did the same sort of choices over weeks, obviously, it makes more and more health differences on it, and it's the cumulative effect of poor nutrition and poor information that is killing our country right now. And you know, we have the choice of either helping our patients go on and thrive, or die an expensive death in there. These guys. Anybody familiar with the health registry at all? This is it's now, I think, in its 7th year. They've been collecting information since 1993, 7 years that I've been familiar with it. And when they looked at these people, all of whom had to have lost at least 50 pounds and kept it off for at least 5 years, some of them have been in there for a goodly while, what they found was they ate breakfast. That was the most common thing. That they did some form of exercise. It would be great if it was 30 minutes every day. But even if they get it 2 or 3 times a week, it helps. That they have some form of support, whether it's family member, whether it's somebody else who's interested in them, helping them, to just pat them on the back, keep them going, keep them interested in what's going on. Using the multiple small meals through the day, keep your metabolism burning. Individualize it. Some people can exercise, some people can't. Some people need to have this kind of food and some people need the other. You can spin it to a certain degree to fit it there. And then they have to climb on the scale once in a while. They have to put on their tight jeans once in a while to see if they still are fitting them. Monitoring it makes a huge difference. In my office, I've got lots of different gadgets. My fat blob helps a lot in there. It helps to just keep things going. I do have support groups for my folks in there. That's how to code it. You don't code for obesity, guys. You just code for their difference. For those of you who are actually doing coding for insurance companies, code for their comorbid problems that are there. Just about everybody has a sore back or a sore knee, or diabetes, or hypertension, or hyperlipidemia. If all they have is obesity, we now have a few insurance companies that are recognizing that as their significant one. I always put it on, but it's 4th on the list. That way you just make sure that you get paid. And the other thing, obviously, is, you know, you got to walk your talk a little bit in there. This is one of the groups, one of the docs in our main group of Take Shape for Life things. And Cheryl has gone literally, in the time I've known her, from looking like the person on the left to the person on the right. She didn't get rid of nearly as many medications as this guy did. And he also has not had any more heart problems. Within my group of patients, the most I've ever had one patient get off is 8 medications, including insulin. My favorite story is a gal who came to me from one of my colleagues, and she came in with a cane, 83 years old, and was sure she was going to die. She just had given up with what was going on. Got her involved with what we were doing. And about 7 months ago, she literally danced into my office and, you know, blew my staff away. She had this screaming bright red dress on. She had lost 85 pounds. She was off of all of her drugs, including insulin. She said, "Well, Doc, I'm not going to be able to see you anymore." And I said, "Well, why is that?" And she says, "Because I'm going to Europe for dance programs. She and her new boyfriend were going to go teach in Europe." So, yes. But I keep a box under my desk that has all of the pill bottles that my patients no longer need. And my greatest joy in the day is having them pitch in their pill bottles. I've got numbers of what that we've done to labs. I've got numbers of all sorts of things. If anybody's interested, I can go through 15 dozen case histories. But what I can tell you is, with this type of a program, if you can get your patients involved, not only are you going to help them be healthier, not only are you going to have this be an ongoing thing where you're not treating their diseases, it's the only thing I do all day long that creates health. Everything else fixes disease. Any questions at all?